SGLT2 inhibitors, or sodium glucose cotransporter 2 inhibitors, are one of the newer classes of medications used in the treatment of type 2 diabetes. These can be identified by their suffix gliflozin. SGLT2 inhibitors help remove glucose from the body in urine by reducing the amount of glucose reabsorbed back into the bloodstream. They do this by binding to the SGLT2 protein and reducing renal tubular reabsorption, resulting in increased glucose excretion through the urine, thus reducing plasma glucose levels. Various trials have shown that on average, SGLT2 inhibitors reduce HbA1c by 0.6 to 0.9%, with the effect being greater in patients with higher starting levels of HbA1c. They have also demonstrated weight loss of up to 4.5 kilograms in conjunction with metformin. SGLT2 inhibitors are one of the few classes of medications that have shown to have cardiovascular and renal benefits, in addition to glycemic reduction. Landmark trials such as the EMPA-REG, DECLARE-TIMI, and CREDENCE trials have demonstrated these. Empagliflozin was associated with a relative reduction of 38% in cardiovascular deaths, non-fatal myocardial infarction, or non-fatal stroke, 35% in hospitalization for heart failure, and 32% in all-cause mortality. In the CREDENCE trial, renal protection was reported with 39% reduction in progression to albuminuria, doubling of serum creatinine, or renal death in patients treated with EMPA, DEPA, or canagliflozin compared to placebo. In Australia, SGLT2 inhibitors are recommended by PBS to be commenced as second-line agent with metformin or third-line agent with insulin. Though they are not yet subsidized to be used in combination with GLP-1 agonists, they have different modes of action and are a good therapeutic combination. If prescribed together, one needs to be on a private script. SGLT2 inhibitors are not recommended for use in type 1 diabetes. International 2020 KDIGO treatment algorithm recommends SGLT2 inhibitors and metformin as first-line therapy for those with eGFR more than 30. Note that eGFR may drop slightly after initiating SGLT2 inhibitors, but should improve again. The renal benefits are observed regardless. There's a slightly increased risk of urinary tract infections and genital fungal infections due to increased glucose in the urine. Very rarely, Fournier's gangrene has been reported. Some may also experience increased urinary frequency, which may lead to fluid loss. Monitoring blood pressure may be necessary, especially in the elderly or those on loop diuretics. Hypoglycemia has not been shown as a concern unless combined with insulin or sulfonylurea. Reduction of insulin dose may need to be considered prior to starting SGLT2 inhibitors. There's a rare risk of euglycemic diabetic ketoacidosis or DKA in people who are acutely unwell, fasting, preoperative, or have a history of excessive alcohol use. This occurs due to lowering of insulin production and increase in glucagon secretion, which increases lipolysis and increases free fatty acids and ketone production. SGLT2 inhibitors are not recommended in pregnancy or lactation due to increased risk of malformations. Patient education points include practicing good personal genital hygiene, adequate hydration, revision of hypoglycemia recognition and management, sick day management, to withhold SGLT2 inhibitors when unwell or with reduced oral intake, and 3 days before proposed surgery, restart when normal diet is resumed. Reliable contraception and pregnancy planning is necessary in women of childbearing age. So in summary, SGLT2 inhibitors are a good choice for your patients with diabetes. They not only reduce glucose levels, but also provide cardiorenal protection and weight loss without the increased risk of hypoglycemia.